So we're going to give you an update on STARS. It's a program that's been going on at Samaritan for about 4 years now, and there's a lot of good work that's been going on. And so I want to make sure that everyone has their phones muted. You can raise your hand. There's a hand raising option on this too. So, or just interrupt at any moment if you have a question as we go through this. But if you take a look at before COVID and during the pandemic, addiction has been an issue in our state. It's been underfunded, unfortunately, across the country. When you look at the cost of addiction, we spend about $6.7 billion annually as a state. And if you look at it, the consequences of addiction consume about 17% of the state budget, while only 1% is spent on prevention or treatment. And so when we look at the dollars spent, the best dollar spent will be on treatment and not incarceration or health care. 6 to 7 Oregonians die of alcohol or drug-related overdoses every single day. So when we look at this epidemic of addiction and substance use disorder, it's significant across the country, but that puts a real fine point on what's happening within Oregon. If you look at it, Oregon ranks 3rd highest in the nation for untreated addiction. Go to the next slide. And the type of drugs that you can see that are being consumed within the state, as we rank amongst other states, we're number 1 for marijuana use, number 1 for pain reliever misuse, number 2 for methamphetamine, number 4 for cocaine, number 4 for alcohol use disorder, and number 21 for heroin. So those are the drug of choice or the drug of abuse within the state of Oregon, but how we rank amongst all 50 states and the District of Columbia. So significant utilization, unfortunately, of these drugs and medications. Next slide. And as you can see, the response to this crisis is just a timeline of where we've been and where we are today. And if we go back to 16, we started talking about what could we do and where could we do it. We had some thoughts about where we would put the residential program. Those changed over time. When we look at in March, we purchased the property in March or April. We then had the teen challenge and old church demolished there. That was right on the corner. We had the facility design and program planning. When we look at program planning, that's both in the inpatient world and the outpatient world. You know, we've had folks where we had medication-assisted treatment. We had outpatient services, intensive outpatient services. Kelley will talk a little bit more about treatment at the end of the presentation, but when we look at that, we've got folks that would come to meetings and counseling maybe a couple times a week, maybe 5 or 6 times a week. So that program development and planning was important to design how folks in the outpatient world would be treated, how folks in the inpatient world would be treated, and then how do we transition patients from the inpatient world to the outpatient world, or discharging them from that residential program back out into back home, and then make sure that they had a plan and structure around their recovery. And then if you look at September, we had the official capital campaign kickoff for $4 million. So that was a significant kickoff. We had fits and starts with that in terms of, it started, and then we had some issues around the legislature taxing our acute care hospitals, Albany and Corvallis. And unfortunately, we had to kind of stall the program. And as you can see, in June of 19 through May of 20, the groundbreaking ceremony and construction. So that's kind of the timeline in a nutshell for us of where we started and where we are today. Next slide, please. So there's the groundbreaking ceremony in June of 2019. We had some of our community partners there with us. We've got Kelley and myself. Some of the commissioners there. Doug Boyson is on the right there. Dr. Heinmarsh right next to right next to Doug Boyson. So those are the folks that we had at the ground that were part of the groundbreaking ceremony. We have the mayor. He's on the far left there. So it was a great ceremony. The opportunity to create this program after talking about it for 3 years was spectacular. It was a great turnout. So that's a picture of our ceremony. Next slide, please. There's the construction. If you remember, unfortunately, I don't think we have a picture of the old Teen Challenge site, building, and the church that was there. And as we go back, maybe to just think about this for a minute, we were when we bought that building, we were planning on renovating that building. It was a big building. They'd used it for adolescent treatment. And so when we went through the building, we bought the property. It was actually a really great purchase price. I think probably one of the best corners in the entire city. It puts 34 and 20 right there on the corner, so it's kind of the gateway into town. We picked up that property. We really considered remodeling that building, and as we kept going through the building and looking at what it would take to turn it into a residential program for us, we soon realized that we would probably spend nearly as much or as much money as the $4 million renovating it. We would still have a 70-year-old building, and I think my motto on it is if we can make this building work, we could definitely treat people and make them better as well. And that motto didn't really stick, and we realized that it was too expensive to remodel that building. So I think in all the wisdom of everyone at the table, we realized that we should tear that building down. As you can see, we scraped all the property there. We moved the building over closest to our clinic there, Main Street Clinic. We recognized a couple things when we were starting to figure out where we wanted to position our outpatients and inpatient services. That's a really busy street, and we wanted to make sure that we were trying to give people privacy and confidentiality for those receiving services. And so we took it as far back off that corner as we could, for one, for privacy, and two, to utilize that space to make sure we could get another building on that corner there. So we moved it back by the clinic. The entry point into the inpatient services is on Main Street, which is the road that parallels Highway 20 there. And then on Highway 20, there's a door there that we use for our intensive outpatient services. So the positioning of the facility on the property was well thought out, well conceived, so that we again could utilize that property for a couple different purposes, but also maintaining the confidentiality of those folks receiving services. Next slide, please. And so after nearly 4 years of fundraising by all three foundations, I got to tell you, I believe this is probably the first campaign. I can't remember another one, and maybe Brandy or one of the other foundation folks, Taylor, I thought I saw you too. I think this is the first actual valley-wide three foundation fundraising events that we had, and we had over 500 donors contribute to the program, and you can see that we shot past our goal of $4 million. I think it was almost $4.4 million raised philanthropically, and it was a collaborative effort, as I said, between the three foundations in the valley. And just and one might ask, well, what about the coast? Did the coast participate? And what I would say is we focused on the valley because we recognized a couple things. One, that we're probably going to need a facility like this on the coast sometime in the future. 16 beds is not going to be enough to treat the 250,000 people within our three counties. The distance between the coast and Lebanon was viewed as an impediment to folks receiving inpatient services more readily. And then the other thing too that was going on, if you rewind about a year, there was still at the coast fundraising for the two hospitals and all the equipment that were going to go into the two hospitals and such. So based on those those two factors, we thought it would be best to focus on the Valley right now, get a 16-bed residential program up and running, have some learnings over the next 3 to 5 years, and then start to engage the coast potentially on a residential program out there, or enhanced services depending on what happens in the next 3 to 5 years. If another vendor were to come in and set up a residential program, I don't know that we'd want to be duplicative out there or create duplicate infrastructure, although I think the need is there for more than 16 beds. So again, it was a very good collaborative effort in the Valley, and it was considered to be a system-wide resource. So next slide, please. And so the facility, if you look at it, the goal of the facility was, again, we wanted it to look nice, we wanted it to look homey. We wanted it to not feel as though it was a clinical environment so much as a treatment facility that was comfortable for folks to be there and to live there for their, and stay there for their 3 to 6 or 7 week treatment course. So again, you can see a picture of the bed there. The rooms are nice size. Again, they're set up in a way that we've got people either in double rooms. We have some single rooms based on ADA accommodations, or just maybe it's not a good fit for someone in the program to maybe have a roommate. But again, most of the rooms are double occupancy. So outpatient services arrived at the facility in June of this year, and based on COVID, we were hoping to have the services up and running back in April. And based on that, it was just viewed as not one being a smart thing to open up at that point. We're still working through logistics of how to test people and get them in, but also we were concerned back in April, May, right at the beginning of COVID. That was a 16-bed facility. We were unsure how COVID was going to impact us from a staffing perspective. We were also, and we still are concerned about that as it ramps back up, but also we were concerned potentially about folks that were in assisted living facilities that might not be able to get back to their facility because they tested positive, and those facilities were not accepting their residents back, which is still a concern today. And the one thought was, we had a brand new building that we could potentially house either staff in, or we could house some folks that couldn't get back to their facility. So for a number of reasons, we held off on opening the residential program until August. And so August, we kicked that program off. And in the kicking off of that program, it just so happened that we had one cohort, and what I mean by that, between males and females, we had one cohort, which were the females, where the wait list was significantly longer for females. And as we were looking at the hiring process, we had hired and had more applicants for females than we did for males. So we were able to get everyone hired and open up with a female cohort. And within about 2 or 3 weeks, Kelley can fill you in on that when she talks about treatment, we then added the male cohort. So we now have from August till today, we've started with a female cohort, and now we're open for both men and women. Next slide, please. So there you can see the building completed, and as you look at the building, you'll see on the right side there where there's a blue sign. That's the entry into the building for the for outpatient services, intensive outpatient services. And if you follow the building down to the left onto Main Street, you'll see that there's an entryway for the residential program. And if you look up on top of the building there, we were able to put the largest heart flame we could on the building. So I wanted to make sure that we had branded the building and folks knew that it was Samaritan's residential and outpatient building. So we got a really nice heart flame up there on top of the building that is lit at night. So it's a nice touch. Again, we were able to get the biggest size up there we could. So I wanted to make sure we had branded our building nicely. So that was nice from the marketing team. They were able to get that taken care of for us. All right, next slide. So if you look at the program philosophy, again, I'll hand this off to Kelley in just a minute here. We're going to get into treatment, but it is a belief that people who are struggling with substance use disorder deserve to heal in a safe, warm, welcoming environment, provide evidence-based practices, and believe substance use disorder can be treated successfully. And when we look at substance use disorder, it's an illness. It's a medical condition. And the part about that is people go into treatment and sometimes they relapse. And if we look at folks with chronic disease management, like diabetes, high blood pressure, cholesterol, it's a lifetime endeavor. They've got to manage it. They've got to do all the right things. And in this service line, in this disorder, again, some people relapse. And so hence, that's why we have outpatient, intensive outpatient in the residential program. People will struggle with this disease their entire life. And so again, we're trying to set up the programs and the philosophy that people feel safe coming to us and that we'll treat them well. Next slide. So eligibility. Our program right now is 18 years of age and older. Lynn, Benton, and Lincoln County by proximity get priority to the building. Well, Kelley will talk to you about illness and how sick people are. This is a statewide resource. I don't know if we have yet, but we will get calls from around the state wondering if they can place a patient with us. There's requirements for that, part of the intake assessment and such. But 18 years of age, Lynn, Benton, and Lincoln counties have priority, but it is a statewide resource. And then we are taking COVID precautions. These patients are being tested before they get into our facility, and I think we're testing them once they're in there as well, just to confirm. So I want to make sure that we do not have a COVID outbreak. But I will say this: once the patients' residents are in, the concern about them once we get them tested is low. Again, the issue for us and all of us, not just in healthcare, but in our personal lives, is a community acquired or community interactions that we have. And unfortunately, we had 3 staff members that had tested positive over there. It did not. None of our patients tested positive. Luckily, they were quarantined. It did cause some staffing concerns and issues that Kelley and the team had to address, but it did not shut us down. And again, we're practicing universal precautions over there and really trying to make sure that we do not have an outbreak of COVID in our treatment facility. COVID is unfortunately unfortunate for those people that get it. Again, without comorbidities of age and a lot of other medical comorbidities, so a lot of folks don't know they have COVID, or they get sick but recover within a short period of time. The unfortunate part is, you saw, we have 6 to 7 people dying daily from substance use disorder, and having this service up and running is paramount to helping those folks and trying to bend that curve of death from substance use disorder. Next slide, please. I'll pass this off to Kelley. Kelley can talk about the treatment modalities and what we're doing around treatment. Thank you, Kelley.
Thank you, Marty. You did a great job. He's become really good at this. He could actually do the rest of it too. He doesn't really need me here. Right now, what we have running, and one thing I would say is it's starting a treatment center during a pandemic is nothing I would ever take on again. So the services that we have going right now, and I'd like to thank everybody for being here this morning, and thank you for having us. We have an outpatient program and we have the residential program. The outpatient program has been up and running for a while, has been challenged by the COVID pandemic. We currently have the first program and first group that we ever started running was the group that was I started about 3 years ago, and that's our women's intensive outpatient, which meets 4 times a week. We have a men's intensive outpatient, which meets at night 3 times a week. We have great counselors in both of those groups. They're very popular, very skilled counselors. The groups are really well liked. We have 2 mindfulness-based groups. We have a mindfulness-based relapse prevention group, which is a women's group, also a very popular counselor. We have a mindfulness-based CBT group, cognitive behavioral therapy group, which I run for men. Getting ready to hand that one off so we can expand into something else, because we are actually getting kind of busy. And then we have a motivational enhancement group, which that's the one that I will probably take over and turn into an orientation group for the holding patients that we have that are on wait lists for different things. Next slide, Brandy. And I guess the one thing before we move on is talking about, we also have grants that we have. And one of our grants, something that we've been working on, and they got off the ground 2 weeks ago, is we now also have a Naranon group for family members. That's not affiliated with us. It's actually affiliated with Naranon, but our staff got that off the ground. That's for family members of substance users. That is currently on Zoom, and I can send out that link later. That's on Wednesday evenings, and I'm really proud of the staff for getting that going. It's a much needed service. Prior to this, the closest Naranon group was in Springfield, and the other one was in Salem, so that's really important. So one of the things that we were committed to when we started here was a trauma responsive environment, and we really understand that people come from all walks of life here. And that, that we're really, that's how we interact with people. It's how we attempt to interact with each other, and we don't do it perfectly. We had an example the other night. I was talking with a staff member last night, and I had approached a young woman in a way that I probably shouldn't have, so I had to go back and I had to apologize to her. Then she told another staff member that that apology meant everything to her. And so we work really hard to be kind and to remember that people come from backgrounds that we don't always know what that background is, and things like talking to them about cleaning their rooms, that sometimes people don't know how to clean their rooms. They don't know what it means to make a bed. We were helping people clean their rooms yesterday, and you just can't assume where people come from, what they know or what they don't know. And also remembering how we talk to each other, that we remind ourselves a lot here that that we role model for the patients in how we interact with each other. Next slide, Brandy. So this is one of our former patients, and one person who individual with me and intensive outpatient, and then Molly's group. And I'm gonna have a hard time. I don't want to talk about her. I'll probably get pretty teary. But this person is just an incredible story. I can remember right back to the first phone call, which came from OHSU after a horrific car wreck. And basically numerous surgeries to repair her face and her body, and who she is now and her spirit of life, and her spirit is just incredible. And what she says is we saved her life, and I don't believe we saved her life, but she found recovery here, and watching her go through the process of every single level of care has been incredible. And I think what we did give her is what she says there is that, we were on her side. Sometimes we were on her side when she wasn't on her side. Next slide, Brandy. At this point, we will open it up for, and what it says there is that is our website, and we do have a wish list. There are things that we still need donated, or if you would like to donate for our library, or things that we do need for the residents here, there is a wish list on Amazon. And if you have any questions for Marty or I that we can answer, then we could do so at this time.
Hi, Kelley, this is Brandy. I was wondering if you could talk a little more about your team, the staff that you have, and particularly kind of the medical side, your medical directors and how that's coordinated, kind of show the expertise of our program, please.
So we have a multidisciplinary team. It starts with so I'll just go from, I don't want to say the top down because it's not really a top down model. It is a multidisciplinary team. And we work as a team. If you ever came to our admission meeting or anything, you'd probably have a hard time walking in and knowing, who's who as far as hierarchy goes. Our medical director is Dr. Richard Highmarsh. And he comes to shift reports, he comes to our staff meeting, he's in our huddle, he comes to our admission meeting, and he helps us, medically clear situations. He is on call. We have 2 nurses. We have great nurses. One in particular who's really the backbone of the medical piece when it's, the medical director is one piece, but it's really your nurses that, day-to-day operations medically help keep us safe. And especially during COVID with staff and patients, when everybody's kind of getting COVID fatigue, it's your nurses that step in and it's like, this is what needs to be done. We have certified alcohol and drug counselors. We have a clinical supervisor. We have peer support. On this side of the building, we run 24/7. So we have residential, in some programs, residential aides. We call them residential milieu specialists. We have a milieu coordinator who helps coordinate the whole environment. We have myself. We also have obviously cooks. So we have the cook is also, we talk about nutrition and what's needed for the folks who come in because they come in pretty ill and pretty, sometimes malnourished and have other nutritional challenges. So it's a whole multidisciplinary team.
John, I see you have your hand up.
Yes. Brandy, could you put that slide back up that showed the addiction rates in Oregon?
Sure, I'll work on that, John. Just give me 1 second here.
Then add some questions for Marty and Kelley on that.
So one thing I will say is that during COVID, the overdose rates have gone up significantly, and we are, as usual, way past the national average. The national average of overdose rates in the nation have gone up by about 30%, and unfortunately in Oregon, they've gone up by about 70%.
Okay, you had that up there a minute ago, Brandy, that one. How in such a progressive state as Oregon does this happen? Maybe we're too progressive.
That could be part of it, John. I think when you look at it, the folks that end up funding the vast majority of treatment are the insurance companies. And when you look at mental health and when you look at substance use disorder, addiction, they've been woefully underfunded for years. And unfortunately, when you look at the reimbursements for Medicare and Medicaid as a state, we don't have a lot of population here, so our reimbursements, we're also disproportionately disadvantaged in our reimbursements. New York, Texas, California, you look at the bigger states, they get higher Medicare reimbursements, and there's greater dollars in the Medicaid programs as well. So they're wildly and vastly underfunded, unfortunately. Heck, when we looked at the pro forma to set up the program, with the building being 100% funded philanthropically, we're still looking at a loss of probably somewhere in the vicinity of $250,000 to $300,000 a year, based on our population and the reimbursement. We have 70% Medicare, Medicaid in this region. So as you can see, there's not a lot of commercial payers either. And across the state, it's just been woefully underfunded. So unfortunately, it's led to a lack of treatment. A lack of treatment leads to generational addiction, generational issues that are hard to overcome. And these programs are much needed.